Most of the times we say, अरे मेरे family में कुछ नहीं है, no history, nothing, that I need not worry, मुझे genetics का कोई खतरा नहीं है. That's not true. Because autosomal recessive disorders, X chromosome related disorders, there could be carriers in the family with normal history, no sign symptoms, absolutely normal. You would never know. You'd never know if couple like husband wife both are carrier for some variant. Family history दिखता नहीं है, but then the child gets it. This is one, like carriers in the family and having a affected individual. Or secondly, there is no history but de novo or pathogenic variants occurring by itself. That can always happen. Nothing in the family does not mean anything. Still we need to have a look.
There are very, very few medical geneticists that are there in India to take care of so many genetics and hereditary diseases. In fact, if we exclude the hereditary diseases, every other medical condition will have genetic predisposition. And for that, we have invited Dr. Anup in our studio today. Dr. Anup is a medical geneticist and he's an associate director with SRL. So let's hear from Dr. Anup Rawool regarding medical genetics and its importance in day-to-day life. What exactly is medical genetics?
Forget the patients and general population, even in doctor community, awareness is not there regarding this field, medical genetics. In MBBS, we are trained to see general patients across specialty to understand the basic ailments. If they are manageable at that level, we manage it. And if they require a specialist care, suppose from cardiology, neurology, we refer them for specialist care, for surgery and so on. So after doing my MD medicine, or say like pediatricians or obs-gynae, once they do specialize in genetics, so this genetics qualification takes the same practice at a next level. If I'm seeing a child with short stature, so after having ruled out hormonal conditions, skeletal conditions, then we think of rare disorders, we think of genetic conditions. So in medical genetics, what we do is, for our routine practice, we add a new dimension to it that we call as genetics. So here, otherwise, as a cardiologist, if I'm seeing a patient, for me, patient's history is important, patient's examination is important. I never venture into family history. People ask, why genetic diagnosis? What good it is going to do? Sometimes what happens is, say for cardiomyopathies, or there has been a sudden death in the family. If this is not investigated, we don't know if anyone else is at risk. More importantly, for certain situations where it could be life-threatening at times, or it could impact the quality of life in a significant way, when a pregnancy is to be planned in the family, we can use this information and provide prenatal diagnosis. So we can help couple take informed decisions even regarding their pregnancies. One real life experience that I had, like I go to Baramati every month. There was one pregnancy where the diagnosis was short long bones. All long bones were short in that baby. And the family, it was well within the window as per PCPNDT, and the family took an informed decision because all growth parameters were way behind. Along with this, they took a decision to terminate. So the doctor called, like, this is the situation. The clinical working diagnosis is achondroplasia and they have terminated. So I said, okay, please do a fetal autopsy later. That is very important. So we got the fetus, we did the fetal autopsy, we stored the DNA, and we also got the DNA testing done. And in fetal autopsy, we also do radio imaging, and we found multiple bony fractures in the fetus. Actually, it was a case of osteogenesis imperfecta, fetus with multiple fractures in utero. We did the genetic diagnosis and we were able to find a mutation and confirm that this is osteogenesis imperfecta. Now look at the condition. Achondroplasia, otherwise parents are normal, is a de novo condition. Risk of recurrence is less than 2%. Osteogenesis imperfecta that the couple had was autosomal recessive. Confirmation was done again in the fetus with Sanger sequencing, and in the parents, both were carriers. Now, risk of recurrence for this OI in next pregnancy is 25%. So, where is 2%, where is 25%? Correct. And with proper genetic diagnosis, we can actually we offered in fact prenatal diagnosis to the couple in next pregnancy. Luckily, next pregnancy, the fetus was a carrier just like the parents, and they carried on.
So, it's helping parents to plan for the next baby. Also to know in advance whether the baby will also have such kind of a genetic mutation or any kind of a disorder.
So the rule of thumb in genetics is always test the proband. Proband is the person who is affected with the condition. If you talk of genetic etiology for any condition, it is a spectrum. At one end, 1-to-1. In 1-to-1, the advantage is the mutation can be predicted or screened in the individuals. So hereditary breast cancer syndrome, breast ovarian cancer syndrome is one such entity where okay, the person is diagnosed with breast cancer, carries a mutation in say BRCA1, BRCA2, mutation has been identified, then at risk individuals, they can be screened. So that is one end. At other end, when it is polygenic, multifactorial, then screening becomes difficult. But management, of course, is there, because whatever the risk, if you adopt healthy lifestyle, your dietary habits, exercise, stress levels, you can mitigate or bring down the risk that is there with all these components. So genetics plays a role in all medical disorders to a smaller or larger extent. So I had seen a family where there was history of some movement disorder in the grandfather who had expired, paternal grandfather. Father was normal, right? Father was around I think in between 45 to 50, and the child was between I think 12 or 15 years, and child had already started manifesting with ataxia. So on screening, it turned out to be a certain type of spinocerebellar ataxia. So there is a phenomenon what we call as anticipation. So in subsequent generation, the same disease condition manifests at an earlier age. So tracing the history, it has come from the father's side. So father's father had it. Now we know father is also at risk.
So coming back to the genetics, so genetics is important for all sort of screening and prevention, right? And it is also important to manage the treatment in cancer. Right? So how actually patients are reaching out to you? Are these the doctors, those who will involve you for the treatment, or the patients, they are so aware that they reach out to you? How your practice actually happens?
Okay, so as a medical geneticist, I get a lot of referrals. So more of it is referrals. So for any specialty, not just cancer, say reproductive genetics, or say pediatrics or cardio, neuro, they undergo the test, the counseling sessions, and then they are sent back with whatever advice or suggestions from my side. But again, at times there are patients who reach out directly from social media, from Google, or any other patients. Just last year, I had one couple from Pune who had been married for almost 12 years. The ladies' two younger brothers had expired due to Duchenne's muscular dystrophy. She had witnessed it from a very close this thing. And her one maternal uncle was also diagnosed with Duchenne's, had expired. Strong family history, and she had seen the suffering, and it had impacted her so much that she was not ready to plan pregnancy. She was scared. 12 years since marriage, and because of this she had not planned, and she had consulted the best of genetic centers in Delhi, in Mumbai, and somehow they shifted to Pune, and they came and visited me. So went through all the details. Incidentally, no genetic testing or workup was done for either her brothers or for her maternal uncle, and no samples were available for them. But other reports were there, NCV, EMG studies that were done, CPK reports were there, and it all corroborated, okay, this is could be the first differential, could be Duchenne's. And also given the pattern of inheritance, from mother's side it is coming. This lady was administered some test in Delhi, and she had those reports, and which said that, okay, she is not a carrier. But again, still, the test was not complete. Only few parts of that gene were tested, a DMD gene, not all. So again, you cannot make a comment. And most importantly, what disease causing variant was present in the patients who were affected, we did not know. So once we don't know, then what to screen, whether it is present in this lady or not. So this is when I realized, okay, there is something known as obligate carrier. So I told her, we'll test your mother first. But she is the common relative. Her brother is affected, her daughter, and then 2 of her sons are affected. So we did the testing for mother. Luckily, we found the mutation in the mother. Then we screened the same mutation in this lady. She was negative.
Okay.
So now I can confidently say, okay, you're negative. You need not worry. You can please plan your pregnancy. But for this verdict, she had to wait for 12 years.
So one is I can definitely see that for pregnancy it is of so much of importance. Do you suggest that anyone who's going for it should be a by default kind of investigation when mother is planning to go
Yes.
for baby?
Exactly. So this is very important question. We need to create a lot of awareness around this topic because whether it is a couple planning pregnancy, that is one, or a probable couple planning a marriage. So I strongly advocate genetic screening at these phases. The screening test will cost a few thousands for the couple, like say between 12 to 15,000, something very doable. So if you can screen and know the risk, and if the risk is there, you can do a prenatal diagnosis. So this prevention screening is much more easier because if a child is born with SMA, first is timely diagnosis, early diagnosis, molecular diagnosis. Second is the treatment part. Now the drug, whether it is available or not, even if it is available, the cost and other things, it becomes very difficult. So in these situations, I see prevention is an important aspect that needs to be stressed. Down south, almost 20 to 30%, maybe more, marriages are in consanguineous relationship. So in these situations, the risk of autosomal recessive disorder, it increases further. So that's why then this screening becomes more relevant in such population.
So what all population or what all couples, they should definitely go for the screening? One is if you are getting married to somebody who's very close relative to yours. If you have, is that so?
I will suggest everyone.
Everyone should go for it.
Everyone should go for. So the proper way of doing it is, if you're planning a marriage or you're planning a pregnancy, please have a genetic consultation. So in that consultation, all these aspects will be discussed and appropriate genetic tests will be administered, and then you can take it forward. So for all couple planning marriage or planning pregnancy, they should have one proper genetic consultation.
My God. So family, they go for the kundali.
Yeah.
Similarly, they should go for the genetic thing. And because of that, there will be so many problems that we can prevent. If we find something.
Yes.
So everyone should go for the genetic counseling.
Consultation, I'll say. So there is a difference now. Patients are most welcome to come and consult. See, we have many queries and everyone has Google Chachas at their disposal. But the thing is that at times it may give a misleading information or a information which is misinterpreted, and then the message is taken. So this creates a lots of confusion. If you have any such questions, please have a genetic consultation. That is my advice, straightforward. So there are certain red flags which I routinely highlight in all my talks. So in your family, like any member having recurrent miscarriages, primary infertility, or IUDs, pregnancy where congenital anomalies were there, neonatal or infant deaths were there, sudden cardiac deaths, sudden unexplained death, or there is a particular pattern for any medical disorder which runs in the family across relatives on, say, mother's side, father's side, which you think needs to be investigated. In all this, or okay, my parents were consanguineously married, or now I am consanguineously married, what could be the risk to my children? Or there is a child with, say, mental retardation, intellectual disability, these conditions, even seizures, epilepsy. Any such occurrences in the family should have a proper genetic consultation at least once, so that proper evaluation is made so as to ascertain whether this condition is actually genetic or not. So one thing I want to just highlight, it is very important, like genetic and inherited are they the same? Are they the different? Or they can be used interchangeably? What do you think?
They are different.
Yeah, definitely. They are different. So anything that is inherited, that is genetic, beyond doubt, because it is through the genes that is being passed on from one generation to another. You rightly said that. On the converse side, whatever is genetic need not be inherited, because that particular disease causing variant could have occurred in that individual by itself for the first time and may remain restricted to that individual, may not go in subsequent generations. So whatever is inherited is indeed genetic, but whatever is genetic need not be necessary that it is inherited or hereditary. Depending upon what is the condition, what is the pattern of inheritance, we will decide whom all to screen. Had this interesting case, patient who actually came down from Ireland. His mother succumbed to CA breast, and that happened like some 3-4 years back. And he was worried because his mother had myotonic dystrophy, and he had recently had a child. Child was hardly 1 month old. So his father was from Ireland, mother was from India, and this guy was traveling to India, came to know like Google, LinkedIn, and all, and he reached out. And he was really stressed, like, I've just had a baby. My mother had so strong history that she had cancer, she had myotonic dystrophy. I'm not worried about myself, but I'm worried about my child now. Will he get it or not? So I sat with him and took the detailed history for his mother, when the symptoms started, when she was diagnosed with CA breast, and what the treatment was done, and how was the course, and when she succumbed. So she had expired just like 3-4 years back. It just struck me, okay, where was the testing and all, everything done? He said it was done in Mumbai in a lab. I was very good. Can you contact the lab and if you can get the tissue blocks? So it was about myotonic dystrophy. Myotonic dystrophy is one condition where there is a risk of breast cancers. Some amount of patients develop breast cancer. So it was mother who had a genetic inherited condition, that was myotonic dystrophy, and CA breast is one of the components. So, and he was worried. We got hold of the blocks. We did the testing that we otherwise do for germline. We do on the blood. We were able to find the mutation. So that was the first success, because nothing of this sort has been reported. Then we tested this person. He was negative. That's the second success. He's gone back happily to Ireland. So he doesn't have to worry about myotonic dystrophy or the CA involved or his child for this particular condition. Otherwise, in these situations like this, like if you have a person in the family who has had some condition which could be genetic or inherited, but you're not able to test, you don't have any specimen, it becomes very frustrating. And it at times, such individuals who are at risk, either they have guilt or they develop some sort of psychological symptoms which affects their daily life. So that becomes very disturbing. So we're happy that this person was on a verge of maybe a nervous breakdown. He had stopped working and all that, and we were able to help him.
And we usually underestimate that the kind of stress we go through, or the kind of anxiety we live with. What if something happens? When we know the history.
Yes.
It's always good to get the consultation done, find out, and even if the samples are not available, you were able to procure the samples somehow. That's amazing.
So let us look at the DNA, right? Interesting molecule, right? So each of us have 2 copies of DNA in each cell. Okay. 1 copy coming from each parent. Each DNA has some nucleotide base pairs. So 1 DNA copy, 3 billion base pairs. So if you look at the population of India is like 1.4 billion. So almost more than double of that nucleotide base pairs. So if you talk in terms of data, it is like 3 GB data on 1 DNA. And of it, the functional region or protein coding region is like 1 to 1.5%. So if you talk in terms of data, it comes out to be like between say 35 to maybe 50 MB. So this 35 to 50 MB is controlling all of us.
My last question for the day is, if I was trying to Google something regarding genetics, SEO will pop with multiple advertisement, get your genetic genetic reports done.
Yeah.
Okay, and one of my friend, he did the report, It was some 100 pages report was there. With some recommendations regarding food or what can be diseases,
Nutrigenomics, diet, health.
Quite many things were there. He understood nothing out of it, and he sent me the report. I said, not my expertise at all. So where are we with that? Like, do we need those reports, or what do I get to know with it?
Such practice and such fancies are catching up in Indian market at large presently. What we call as predictive genomics. So it's a total different segment. So what I am into is diagnostics. What you mentioned is predictive genomics. So here it is not diagnostics. It's more of a screening. So this predictive genomics, it looks at the polygenic aspects. So if it is increasing your risk or negating your risk, those things. So it is not purely diagnostics. Whatever the report is, if you have a post-test genetic counseling session, those aspects of the report, whether it is positive, negative, if there is a high risk allele for any particular conditions, those will be discussed in post-test counseling. But we should, again, I'll highlight, these are not hardcore diagnostic tests. So we have to understand the limitations of predictive testing, right? Because suppose if someone has a family history of any particular medical disorder, say sudden cardiac deaths or cardiomyopathies or cancers or eye related conditions like age related macular degeneration, or say neurodegenerative conditions like ataxias, Huntington's and so on. So for them, diagnostic genetic testing is a must. This is different. Predictive is different. Different.
It's like good to have, like,
yeah, good to have, but if you have a history or risk is known, better to go for diagnostics and better to go for a proper medical genetic consultation.
A couple of takeaway message that I understood, that anywhere there is a family history, then make sure they should talk to you. And most importantly, for so many clinical conditions, there is so much of genetics advancement that is there, whether we talk about cancer or ophthalmological conditions you talk to. So it's also important for doctors to understand what you do and involve you into their treatment for a better outcome for the patients.
And thanks for hosting me.
Thank you so much.
Thank you.